Aloha! The CME activity is jointly provided by the Queens Medical Center and UH-JABSOM Department of Geriatric Medicine. As a reminder, evaluations are required for certificates of attendance. After you complete an evaluation, a certificate will automatically be sent to you. You can find evaluations by following the link in the chat at the end of the session or at any time on our website and email advertisement. We are on month 2 of a 4-month series on the mind. In the evaluations, we'll be asking you about how many of your residents have been screened for dementia and depression and how to assess for delirium. I will be staying on after with you to show you how to complete the evaluations. About ECHO, we want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO model goes, all teach, all learn. So it will take all of you to create this community of learning. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open up the time for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to topic of today's lecture. We only ask that you keep it HIPAA compliant for discussion. That means please do not share patient's name, birth date, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Wynette Gaylord, president of ARCA, a care home operator association. We also have Maribel Tan, president of Foster Family Homes Association, Danielle DeLonghi from Aloha Care, Leila Ventar from United Healthcare, and Dr. Ritabel Fernandez from University of Hawaii. We recently finished a 4-series on medications. If you're interested in viewing any of those lectures, you can find them on our website. We cannot offer certificates of attendance for videos you have viewed, unfortunately. You must participate in our education live to receive a certificate. We are now on a 4-month series on the mind. This month, we'll be talking about mild cognitive impairment and dementia. Now it gives me great pleasure to introduce our speaker, Dr. Ritabel Fernandez. Dr. Fernandez is an associate professor at the Geriatric Medicine Department of the John A. Burns School of Medicine, University of Hawaii. She is a practicing geriatrician, Kalihi Palama Health Center, and also an associate medical director at Islands Hospice. She graduated from medical school in India in 1995 and moved to Hawaii in 1999 to study geriatric medicine at UH. Dr. Fernandez has served on the Doctors Work Group for the State Task Force on Alzheimer's disease and related dementia. She was the co-principal investigator of the Hawaii Alzheimer's Dementia Initiative, a grant from the Administration for Community Living. Dr. Fernandez has championed memory clinics across the state to provide comprehensive dementia care. Take it away, Doc.
Good afternoon, everyone. So happy to be here with you all, and I'm so glad to see so many attendees from the care homes and foster homes. That's awesome. We have such a good showing. Thank you for coming today. We are going to talk about mild cognitive impairment and dementia. This is a very important topic because you will see that more and more people are getting diagnosed with dementia, especially after the pandemic. So let's get started. I'm wondering whether you can see my screen.
Yes, we can.
All right. I'm trying to get into slideshow mode. Is it in a slideshow mode? Is it showing full screen? For you, Wynette, can you see it as a full screen or half?
No,
It's-
it's not.
It's only 75% of the screen.
Yeah, resume slideshow. Okay, how about this? Now I think it is full screen, probably, but it's gone gray. Slideshow from beginning. Sorry, technical challenges, but here we are.
Here we go. It looks
Okay.
good now.
Thank you, Annette. Thank you, everyone, for your patience. So I want to begin with first, what is normal aging? My parents, they live in India. My father will be 94 this year and my mother 86. And often my father and mother will ask me, they'll tell me something and then they'll say, is this normal? I'm always asked whether something is normal or not. So I want to start with what is normal. Let's look at the brain. What happens as we grow old? We will notice that there is some slowing of the neurons, but intelligence remains the same. You might have difficulty doing multitasking and when you're young, you can be on Facebook, you can be cooking, babysitting, you're doing so many things at one time. But when you get older, you want to just focus on one task. There may be mild short-term memory loss, but it doesn't affect people's activities of daily living. It doesn't affect them, their ability to live alone or carry on their life. They might have a difficulty for a word and they may say, give me that, but they know it's a pen. They know it's a cup of water. So that's what you will see in normal aging. Now, another question I'm asked is, what changes the most and what changes the least? As we get older, you will notice that reading and vocabulary change the least. We learn to read at such a young age, and it is one of the last things to leave us. We learn to speak as a baby. We learned all these social skills, and that will change the least. So you see a lot of elderly persons, even if they got cataract and glaucoma and they're wearing their glasses, they love to read the Bible. They love to read the newspaper, the midweek, all the mail, including the junk mail. But as we get older, what changes a lot? Now you will notice people get slower. The motor speed slows down. There's problem with visual spatial skills. That is relationship of one thing to another thing. You notice people fall a lot because they are mistaking shapes and images. They may have difficulty if you give them, Mom, I love you, here's your new iPhone. Oh, they don't know how to use the new phone because that is more difficult. So these are the changes we will see in cognition as we get old. And I'm still talking about normal aging. So in normal aging, people can live independently. They don't have to be in a care home or a foster home. They can do things like cooking, driving, managing their medicine. Now somebody may tell me, oh, but auntie doesn't cook. Then I say, did she ever cook in her life? Maybe she was not the cook in the house. Maybe someone else did the cooking. But you will see whatever they can do or whatever they did in the past, they can still do that as they get older. People can still live independently. Their memory is intact for recent events. And if you did a memory test for them, they will pass. They should pass the cognitive screening or the test the doctors will administer. Now, what is this continuum? I want you to think of aging as a spectrum. This is like heart disease. You remember in the old days, we heard about chest pain and angina and heart attack. And now they are telling us coronary syndrome. They're saying it's a syndrome now because it's a whole spectrum. So even in cognitive changes, we are noticing a spectrum. It's not so black and white that there's normal and there's people with dementia. Now we are going to see even a gray zone coming in between of these two. So what is this mild cognitive impairment? MCI is standing for mild cognitive impairment. It is like the middle stage. It may be the boundaries between normal aging and dementia. It was first described by Dr. Peterson in the Mayo Clinic in Minnesota. And what they're saying is that maybe mild cognitive impairment can identify people who are at risk for dementia. So this is what we're looking at now. Instead of just black and white, we have now this gray area in the middle, right? I'm telling you to think of this like a syndrome, like a spectrum. So we have normal aging, then you might have somewhere in the middle called mild cognitive impairment, and then later people may develop dementia. So what else do we see in mild cognitive impairment? It is characterized by mild but measurable changes in thinking ability. That means there is something going on, but the person doesn't meet the diagnosis of dementia. They could still pass on the tests. People can still live alone and they can still do their activities of daily living. So what is the diagnostic criteria? So the diagnostic criteria is someone is concerned about the patient's cognitive status. Maybe the daughter is worried about their mother's memory. Maybe the doctor thinks something is going on. There may be objective evidence of impairment in one or more cognitive domains. There's general maintenance of independent function in daily living, and they can manage with minimal assistance, and the person doesn't have dementia. So what this is telling us is somebody feels something is not right. Somebody, maybe a family member, maybe a care home operator, maybe a foster, you think something is not right. But people are getting good marks on their tests and the doctor is saying everything is okay. They may fall in this gray zone called mild cognitive impairment. And often what I am seeing in the chart is many times when you look at the medical chart, they don't have the diagnosis of dementia, but they are putting diagnosis forgetful, memory impairment, forgetful. If you see these two things like memory impairment or forgetfulness, maybe this person has mild cognitive impairment. Maybe there's no full-blown dementia, but there could be mild cognitive impairment. Now, what fools us in this category is that there is no significant impairment in social or occupational functioning. So they can still go to church, they go to bingo, they go to their Zumba classes, they're doing just fine. They're able to function good. Now, there are two types. There is two subtypes of mild cognitive impairment. The most common one is called amnestic mild cognitive impairment. Here, memory is the primary problem. So, people think something is wrong with mom's memory. But if you say, Mom, how's your memory? She'll say, oh, my memory is excellent. My teachers told me I was so smart, I had very good memory. So you will notice they don't think anything is wrong. But somebody is suspecting something may be a little off over here, especially with the memory. So that is amnestic mild cognitive impairment. Then you have something else called non-amnestic mild cognitive impairment. Here, the memory is pretty good, but some things are not making sense. Like language may be funny, maybe their reasoning is off, maybe their judgment is poor, maybe they're doing things that are not appropriate, or that is not culturally sound, and you're wondering like, why? Or what's going on here? So that is the non-amnestic subtype. So how many of these go on to develop dementia? For persons with mild cognitive impairment, we notice that in 5+ years, more than half more than half of them will develop and get a diagnosis of dementia. So the ones with the amnestic mild cognitive impairment, where memory is the typical concern, they go on to develop Alzheimer's disease. And the one where something else is off, like their judgment, or they have something else that is a little not right, that is the non-amnestic mild cognitive impairment, and they may develop like Parkinson's disease, Lewy body dementia, frontotemporal dementia. The other types of dementia are more common. So what are the challenges we are facing? Because some of you may be on this call today and saying, this is the first time anybody's telling me about this one. Maybe you heard about dementia before. A lot of you have heard of dementia diagnosis, but maybe some of you are saying, this is the first time I'm hearing mild cognitive impairment. So this is the diagnostic challenges, because the doctors and the nurses, they're unsure. They're unsure whether this is normal aging. They're unsure how to distinguish this from dementia. And this is a new diagnosis. This diagnosis was described and published by Dr. Peterson from the Mayo Clinic in 2011. So it's not been around for so long that many of the doctors, when they went to medical school, they never learned about this one. There is also some hesitancy. So you will notice there is diagnostic challenges, and then people will say, what do you want me to do? Anyway, there's no medicine, or there's no medicine approved for this diagnosis. So we have some challenges with mild cognitive impairment. Any questions on mild cognitive? You can put it in the chat and we will get to it when I finish. So if it's in your mind, put in the chat and we will address it later. I'm going to move on to dementia. So how common is dementia? More than 5 million Americans today are living with Alzheimer's disease. Nearly 1 in 3 seniors die from Alzheimer's. And this number is only increasing. You know, rates of cancer is going down, rates of heart disease is dropping, but rates of dementia is not dropping. It is only increasing. Now, remember, dementia is not a part of normal aging. Not everyone who grows old will develop dementia. So you may ask me, how common is this? If you're over 65, it's 1 in 9 persons. If you're over the age of 85, it's 1 in 3 persons. What about Hawaii? We think there's approximately 30 to 35,000 people living with Alzheimer's disease in Hawaii. Now remember, it has become the 6th leading cause of death in the US. What is the #1 leading cause? Heart disease. You're right, it's heart disease. But we got to remember, Alzheimer's has now come to #6 position. Now, many people look at me and say, I don't believe that, Dr. Fernandez. It cannot be 30,000 only. And you're right, it cannot be 30,000 or 35,000. Because especially if you're a nursing home, care home, foster home business, you know there are many, many, many people with dementia. And what I say is we are looking at the tip of the iceberg. For those of you who may have gone to Alaska or gone on a cruise, you may have seen icebergs. So what is an iceberg? Greater portion of the ice is below the water. It's below the surface. In the same way, many people with dementia are not even being diagnosed. It is hiding below the surface. And it's being missed by so many people because families, what do families say? Oh, he's just getting old. Oh, mom is just getting old. It's old age. So often this diagnosis is missed. Again, let's look at the differences between normal aging and dementia. In normal aging, a person may forget a name or appointment, but they remember it later. In dementia, there is memory loss that disrupts daily life. In normal aging, a person may make an occasional error when balancing a checkbook. In dementia, we see a lot of challenges in planning or solving problems. In normal aging, a person may say, hey, can you help me record the show? Or can you help me set the microwave or the oven? But in dementia, there is total difficulty in completing familiar tasks at home, at work, at leisure. In normal aging, a person might be confused about the day of the week, but will recall it later. In dementia, you'll notice there's a lot of confusion with time or place, and they tend to argue with you, and they tell you it's your fault, you're not remembering correct. So you will notice they are getting very mixed up with date, time, appointment, and they have calendars. Sometimes they have many calendars because they know that they are forgetting. In normal aging, you might see vision changes related to cataract. But in dementia, we are seeing changes in the brain from dementia affecting the vision control in the brain. So our brain controls our walking, talking, speech, our vision. So they get those areas affected, and they have problems understanding shapes, sizes, figures, visual images, and people fall more often. In normal aging, a person might have trouble finding the right words once in a while, but in dementia, they have problems with words. They may make up new words also. In normal aging, a person may misplace things once in a while, but then they can retrace their steps. In dementia, they are misplacing their things and they have no ability to retrace their steps. In normal aging, a person may make a bad decision once in a while. In dementia, you see decrease or poor judgment. Now, if it's your birthday and you get one envelope or you get a card and that envelope has no money in it and you say, no more nothing, that may have been an auntie with dementia who forgot to put the money in. It is still in her pocket. So you often see decrease or poor judgment. In normal aging, a person might feel weary of work, family, social obligations. In dementia, you see a total withdrawal. They just want to stay in their room. They want to stay in their house. They don't want to go out. They don't want to go to church anymore. There is withdrawal from social activities. In normal aging, a person may have a very specific way of doing things and they get irritated if their routine is disrupted. But in dementia, you see them getting irritated, agitated, confused, mood, personality changes. They may have delusions. Somebody's robbing their money. Somebody's robbing their things. Maybe they have a delusion their spouse is cheating on them. So you see a lot of behavioral problems with dementia. If you have questions about the difference, please put in the chat and we'll get to your question about this, because it can be a little confusing to differentiate between normal aging and dementia.
We do have a question. We do have a question, but it's about vitamins and supplements. I don't know if we want to come back to that.
We'll come back later when in the second half, we'll get to the vitamins and supplements. That's a great question. Great. So there are many causes of dementia. You can get dementia from a head injury, like we have our Samoan NFL players. They get dementia early because they could have had so many injuries to their brain. You can get dementia from Parkinson's disease, from heavy alcohol use, from AIDS, from so many things. But the most common one is Alzheimer's disease. Now, people ask me, what is this Alzheimer's disease? So I want you to think of the flower world. We have so many beautiful flowers in Hawaii, but I may say probably plumeria is the most commonest flower. It's nearly in every home or every street I go down. In the same way, there are many types of dementia, but the commonest one is Alzheimer's dementia or Alzheimer's disease. How common is it? It's close to 75% of all the dementias is Alzheimer's disease. Now I'm going to show you a short video which will explain Alzheimer's disease very well.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part.
So this video, if you want to see it again or show it to someone, it's available on YouTube. Okay, you can see this video again if you like. It's on YouTube, freely available. I know it's a sad video, it's depressing, but there are a couple of good things that this video does. It explains the stages of Alzheimer's disease. You can see what happens at early stage, middle stage, late stage. Another very interesting part in the video, if you remember, that said the oldest memory is the last to go. They will forget what they did in their childhood, where they grew up, and that will go last. Now, what happens, I have seen so many times, family tells me, Nana is awesome. I've had family tell me, Nana has no dementia because Nana can remember growing up in the barrios in the Philippines. Nana can remember going fishing, making kankanan. She can remember her childhood, but Nana cannot remember what happened today or yesterday. So remember that the old memories last to go, and that's why families, they get fooled. Families think, oh, person doesn't have dementia because they're talking all these old stories. So the family thinks, oh, my grandma's mind is very strong. So just remember that part of the video. So this is a photograph of Dr. Alzheimer. He was a pathologist, a German pathologist, who was the first one to describe this disease. So this is what it looks like in the brain. We have these plaques and tangles causing cell death. Now, remember, we cannot do brain biopsy, right? You don't hear of brain biopsy. So if at all you're going to see this, it's only after death. If a family wants an autopsy, if you want 100% diagnosis, then you would do it on autopsy. So what do we see in the brain? We see the brain is shrinking. It is getting smaller. And you can see this on X-ray. You can also see this on CT scan. If the doctors order a CT scan or an MRI, you can see the areas of the brain is getting smaller. And that red, green, and blue areas, that's the hippocampus. Those are the memory centers which have become smaller. Now, many people get so worried and frightened and ask me, Dr. Fernandez, am I at risk for dementia? The greatest risk factor is age. The number one risk factor is age. But also there is strong link to see, or they say what is good for the heart is good for the brain. What's bad for the heart is bad for the brain. So remember, blood pressure, diabetes, cholesterol, all that increases risk factor for dementia. If you've had brain injury, you're at higher risk. Another category of people who are at higher risk is Down syndrome. Persons with Down syndrome are at higher risk. So the stages, in the early stage, people can still function, but they're more confused and they're argumentative about their date, time, appointment. In the late stages is probably what you might see in your care homes and foster homes, where people are mostly bedbound, they don't talk much, they're losing weight, they may have bed sores, they may have urine infection, pneumonia, COVID, all that we're seeing in the late stage. One of the excellent things to consider in late stage is referral to hospice, because you can qualify for hospice under dementia. You don't have to only have cancer for hospice. And I will end with these 5 messages. This is from Dementia Friends. Those of you who have your phone, I know everybody got their phone. Please open your phone and you can go to Facebook. Say, I'm encouraging you to go to Facebook during this echo session. I would like you to become a Dementia Friend. So we have Dementia Friends Hawaii, Dementia Friends America. You can like them and follow them and see what is going on all over the world with Dementia Friends. This was a movement started in the UK. It started in countries which had much more elderly population than Hawaii or US. You know, UK, Japan, their populations have been aging for a long time. So they created something called Dementia Friends. And the key messages is dementia is not a part of normal aging. Not everyone who grows old will develop dementia. Dementia is caused by diseases of the brain. Remember, it is a brain disease. It's not a psychiatric disease. It's not something where you say, oh, he's gone mental or she's gone mental. No, it's a brain disease. And the most common is Alzheimer's disease. Dementia is not just about having memory problems. It can affect thinking, communication, and doing everyday tasks. It is possible to have a good quality of life with dementia. Remember, there is more to the person than dementia. People with dementia are a valuable part of the community. So I thank you for your attention, and I am happy to take questions at this time.
No one has any questions, I'll go ahead and read the chat. Anyone have any questions to ask?
Does metformin increase the
Can you say that one more time, Donna?
Does melatonin increase dementia?
Okay, we have a question about melatonin. Whether melatonin causes dementia or helps dementia or make it worse or make it better. The answer is melatonin is not linked as a risk factor, as a causative factor, or as a treatment for dementia. Right now, there is no association between melatonin. So if you give your clients melatonin, it's not going to cause dementia. And if you have a client with dementia and you give them melatonin, it's not necessarily going to make the dementia better. Though melatonin is often prescribed for people who are having sleeping problems. And if you remember some of the older lectures we had in earlier this year in ECHO, be careful of the dose of melatonin. Don't give 5 milligram, 10 milligram. You may often have to start at a very low dose. Thank you for your question.
On the topic of supplements, Roma Robles had asked, can vitamin supplements help to prevent dementia or Alzheimer's?
Can vitamin supplements help to prevent dementia? One of the things that prevents dementia, and where all the studies are, multinational studies showing effect, is in exercise and a good diet. So exercise is really good to keep your brain and mind active, and good diet. By what diet are we talking about? Because it's confusing. There's diabetic diet, there's hypertension diet, there's so many diets, keto diet, paleo diet, Atkins diet. It's confusing. Now, the diet that is shown to help dementia is called the MIND diet. What does the MIND diet stand for? It's the Mediterranean intervention for neurodegenerative delay. And the MIND diet tells you to have the Mediterranean diet, like olive oil, fruits, nuts, fish, leafy vegetables, legumes, all that is promoted. And you have to keep the salt content a little down. So it's the Mediterranean diet, and the DASH diet put together is the MIND diet. And stay away from red meats, butters, saturated fats, and those kind of things. So then I get the next question is, Dr. Fernandez, do you know how expensive olive oil is? And we are in Hawaii, we are not in Italy or Spain. So what is in olive oil that's so magical? It's something called oleic acid. Now, it's different from our macadamia nut, which is a monounsaturated fatty acid, is very good in macadamia nut. But olive oil has something in chemistry called oleic acid. That fatty acid is found in avocado. And we have the best avocado in Hawaii, right? You don't have to buy the one from Costco, the Mexican avocados. Please be nice to your neighbors. You may get lovely, free, beautiful avocados from your neighbors. So try to eat an avocado every day. It's good for your eyes. It's good for your brain. It's the good, healthy fat. Thank you for that question on diet. So coming back to the supplement, if your client doesn't like to eat different foods, or they're like the chicken nugget patient who just wants chicken nugget and French fries, and you have tried and you cannot get them to eat any fruits and vegetables, then I would say you can use supplements because their diet is so poor. Or if you can't get them into the sunlight, then I would say give a vitamin D because they're getting zero sunlight. So look at your client and then make that determination.
We have another question here from Mary Jean. She's questioning advanced dementia can be qualified for hospice. Someone is still able to eat with assistance and 100% assist on all ADLs. Would that person qualify?
Yes, by the sounds of what you're telling me, the person might qualify. And in hospice, we look at the full picture. Maybe that client had COVID last year. Maybe the doctor gave them some antibiotic for a bronchitis. Maybe something else happened. So when you are considering this, I would say let the hospice decide, because they're going to look at the notes, they're going to look at the hospital records, the ER records, and they will make a determination. But from what you told me, yes, that client could most likely qualify.
There's a couple other questions that are popping up here. So Jamal said, what activities do you recommend for folks that have Alzheimer's in care homes? Type of activities.
Okay, activities that stimulate the brain. So it's important. So what do I do with my mom? My parents visited me last year and they stayed with me for 6 months from India. I said, please come for your visa. It allows you 6 months, you stay for 6 months. So what were we doing with my mom, who is now diagnosed with dementia? The activities that we were playing nearly every day in our house was Scrabble. Why? Because Scrabble is making you think, making you come up with new words. And the funny part is my dad, he's making words like cat, dog, mat. And my mother, who has dementia, she wants to make big, big words. And she wants to win the game. So Scrabble is good. Color Sudoku is good. Crossword puzzles are good. So these are things you can do in the care home. You can play these games with your clients. Bingo is good. It helps them remember their numbers. Anything that's keeping the brain active besides physical exercise. So if you want to turn on the radio, let them dance. Physical activity is good, as well as we want to exercise their brain. And maybe they like to be on their phone. Some people ask me, should they encourage their parents to be on the Facebook and all these things? I said, let them do it, because they are still engaging their brain, whether they are on Facebook, Instagram, whatever. Let them keep their brain busy. So encourage all these activities. And what's even better is if they can learn something new. So guess what we have in Hawaii? We have a hula study, hula to prevent dementia. And that is going on right now with the John A. Burns School of Medicine. The Native Hawaiian Division has the hula for dementia study. And they're looking for participants, especially people with early stage of dementia and people who can dance and get out of their house. You can refer your loved one, your family member for the hula study. In fact, I put my mother in a hula camp when she was here. So why is hula good? Because you are going to learn new words, you are going to learn a chant, you are going to learn the culture. There is so many things that they're going to teach you in hula for dementia. So anything, something new for the brain is very, very good. Thank you for that question, Jamal.
So we have an interesting one here. It says some caregivers, although someone has lost their ability to eat or swallow, some caregivers still try to give Ensure by using droppers to prolong life. Is this violating the client's right for a good quality of life, and what is your advice?
It's a fine line between helping somebody to eat versus force feeding them. So you might say, maybe I am helping them with a spoon, or maybe they can't use the straw very effectively. Maybe I'm doing what the speech therapist told me to do. In the end, Ensure doesn't prolong life. I want to make that clear. Tube feeding also, there is a lot of research and data to show a tube feeding, a PEG tube, will not prolong somebody's life. In fact, it may shorten their life because they may get aspiration pneumonia, they may get complications from the feeding. So this kind of using a dropper or a syringe actually is not prolonging life. But if that is the only way for the nutrition, because maybe the family said no PEG tube, maybe the doctors felt no PEG tube. So if you have no PEG tube, maybe all you have is the mouth, the oral route. So it's okay to use Ensure. We have a lot of clients on Ensure, on Boost, on different supplements. And that is just to keep the basic nutrition for helping them survive. That is not, I wouldn't call it force feeding. And one needs to look at people's advanced directive. Because in advanced directive, when we look at feeding, we are typically talking about artificial feeding. Artificial feeding like a tube in the nose or a tube in the stomach. So maybe using a straw or using a syringe or using a spoon or using a fork or a knife may not be considered artificial feeding. That may be considered still helping the client to eat normally versus a PEG tube or a stomach tube or one of those kind of feeding. You will have to do, what the client feels and the family feels that is in their best interest. That's a tough one. It's not an easy call.
Case by case, sounds like. And maybe family input, yes?
Yeah, or have a family meeting. You might like to have a family meeting and say, maybe it is taking 3 hours to feed with the syringe. Is it worth it? Or maybe I'm using the syringe and they're coughing more and they're choking. So these kind of things need to be brought to the family's attention, and having one of those discussions or letting the doctors facilitate one of those discussions will be important to understand what is the goals of care.
So we have a question going back to keeping someone active, right, and engaged. Ruby says if they're ambulatory, encourage daycare programs. She has 2 clients and her mother-in-law with early dementia, and they attend a community center, and they love it. So that's just a suggestion. Does anyone else have anyone attending a daycare program?
Excellent suggestion. Daycare, day health are very good. Juanette, you were going to say something?
I am. Well, I actually encourage families, if they're currently enrolled in the daycare, to do a transition period if they're coming into the care home. So maybe stay at the routine that they're currently doing, like a Monday, Wednesday, Friday, and then wean them off of the daycare and transition 100% into the care home. So that's another option.
And daycare is very useful for moderate dementia. If somebody has moderate dementia, daycare. However, daycare is not free. Daycare costs money. Now, where can you get free activities? At a senior center. There we go, Moyili Senior Center. So you can get the activities at a much reasonable cost. We even have the Waikiki Community Center. So look at the different senior centers Waianae has. So these are excellent options to keep people busy, make new friends, social connections, not feel isolated, exercise, and all of that is good for the brain.
I don't see any other questions. Does anyone else have a question for Doctor? Topic today.
There's a lot of supplements on the market that they do entertain that it does prolong people's memory. What do you feel about that?
Okay, the largest study was done on ginkgo biloba, because first there was vitamin E, ginkgo was shown to help memory, especially from European studies, but then very big trial done here did not show any benefit for ginkgo biloba and memory. So when we're talking about the supplements that you can get in Costco in Sam's Club, a lot of them are lacking the FDA backing and studies. So these are more, it's up to you if you want to take it or not. Many of them have got vitamins like B vitamins. If you eat a good diet, you will naturally get your B vitamins from your fruits and vegetables. You will get your antioxidants from your fruits and vegetables. You don't need a supplement for antioxidants. So it goes back to individual client, their diet, their food choices. If their food choice is very poor, like if they're just chicken nuggets and French fries all the time, then yes, maybe a supplement may be a good idea for that client.
Well, I know the most popular one that I have in my care homes is Prevagen. So we actually talked to the doctors about it, and quite a few doctors do not encourage them to take it. They think that it's a waste of money. But I say, I guess it's family. If they want to spend the money, go ahead and do it.
Right now, it's a harm risk benefit ratio. If that supplement is not causing any harm, then fine, go ahead, because you're right, it is the family's choice if they want to spend money or not on these things. And if that supplement doesn't interact with their other medications, because you got to be careful, some of these drugs may interact with their regular medicines. But right now, all the drugs we have and all the supplements we have over the counter, none of them are showing much effect on memory, including drugs like Aricept for dementia or Namenda. Their effect is very minimal. So big money right now is in research and trying to develop a vaccine for Alzheimer's disease, better drugs, and newer modalities for testing. So we don't have the answers yet. As of 2023, we don't have good medicines, including the ones that the doctors prescribe is not very good.
I'm curious what your thoughts are, and this is just coming off the top of my head. Probably Dr. know the most about the research that is going on. Do you think we'll see a cure at some point?
Say the last part again, Danielle, please.
Oh, I'm sorry. I was asking if you think we will see a cure at some
Will
point.
we see a cure? If you remember the news in July, what was on the news? We had this new drug that is approved, Leqembi. Leqembi is approved for Alzheimer's disease. But do you know how it's given? It's given in an injection. Do you know how often it's given? Every 2 weeks. And it's only for early stage of dementia. And there is still side effects from that drug because people can get bleeding in the brain. So it's not that we have medicine without its side effects. So far, the ones that are just recently come on the market are these injection drugs. And they are the newer medicine, but still that is not achieving a cure. What these newer injection drugs are trying to do, it's trying to remove the plaques and the tangles in the brain. You remember the video talking about those amyloid plaques and the tangles in the brain? The newer drug is trying to dissolve that amyloid and remove it from the brain cells. So they are given over 1 to 2 years. So remember, Leqembi would need injection every 2 weeks for nearly 2 years. And still we are not at a cure. So I'm sorry, I don't have any hope to give you as far as new medicine or a good supplement or anything. I would still encourage where a lot of the good research is showing is exercise, social connections, leisure activities, and eating a good diet.
Jamel, did you want to offer that? I mean, did you want to share that? I'm not quite sure if it's a question or you're sharing a resource.
Yeah, I'm just sharing a resource. We're definitely working a lot of PSA, including with Dr. Fernandez, I know, but this was done about a month ago. So I know Tani, I guess, is one of our newest Alzheimer's coordinators. So she's working with all our community partners and, setting up all this PSA announcements to help, again, bring awareness to Alzheimer's and, the different methods and ways that we can help our dementia residents in all the different long-term care settings. So definitely appreciate all you folks for, working with your residents, especially those who have Alzheimer's dementia. So thank you.
Thank you, Jamel, and we're so happy you are joining us. You are our long-term care ombudsman, and we're happy that you are at these echo sessions. Thank you for sharing this link. We have a link put up by John in the chat, and that is your link for evaluation and to get your certificate of attendance. So very important to click on that link. And John, may we have the next slide, please? Kindly take the time to do your evaluations. We have Juanette, Maribel, Michaela. They are all here to help you do your evaluations, because part of our grant, we want to know how many people are being screened. And you are a care home operator and a foster home operator. Your role is more an advocacy role. You are advocating for your clients that their doctors, their nurses, screen them for dementia, screen them for delirium. So we have these tools, and we just want to know how many of your clients at least got the screening. They do screening for blood pressure, they do screening for diabetes. So these are important things to look at with your senior citizens, screening for dementia, depression, and delirium. Next slide, please. So evaluations are emailed out. Please double check the spelling of your name and email address. We have John. He works very hard after this 1 hour session. There's a lot of work that goes on behind the scenes to get you your CME credits and to get you your certificates. And I thank Juanette and Maribel for helping us so much to get all of this work done.
Do you want me to wrap it up, Doctor?
Yes, please, Juanette.
Thank you. So I do want to send out a special mahalo to all the attendees today. We thank you for attending the ECHO every month, third Thursday of every month. We appreciate the support, and aloha. I'm going to stay on if anybody needs any assistance filling out the evaluation forms or the tools that we have to complete.